Let us discuss about osteoporosis today. So let us first start with how a normal bone is formed. So let us take this as the normal bone. So this is formed by cells known as osteoblasts. So this osteoblasts form a bone which is a soft bone in which mineralization happens. That is, calcium and phosphorus is deposited, resulting in the formation of the hard bone. Now this bone is under a constant turnover. It is resorbed by cells known as osteoclasts. So throughout life, bone is formed by osteoblasts and is resorbed by osteoclasts. This process is known as bone remodeling. Now what happens with advancing age is the rate of bone resorption becomes more than the rate of bone formation, thus resulting in a reduced bone mass, which is known as osteoporosis. So osteoporosis, as the name suggests, is a porous bone disease. That is, there is a quantitative bone defect in the bone, right? Now let us discuss what are the risk factors for osteoporosis. So the risk factors for osteoporosis can be classified as non-modifiable and modifiable risk factors. Non-modifiable risk factors include advancing age, right? Female sex, of Asian origin, then with a positive family history of osteoporosis related fractures, right? So all these are non-modifiable risk factors of which we cannot change much. What are important is modifiable risk factors, which include number one, nutrition. So a poor nutrition lacking calcium and vitamin D is a major risk factor for osteoporosis. Calcium intake in India, we know, is majorly from milk and milk related products, right? So now individuals with a poor socioeconomic status cannot afford milk and milk products, therefore lack calcium in their diet. Also, there is a disproportionate distribution in milk in families. Male predominantly get milk, right? This is the sad reality. So females have a poor calcium intake since childhood. Similarly, there is a nutritional deficiency of vitamin D intake as well, right? So again, sun exposure is another risk factor for vitamin D deficiency. Now the traditional parda system, the completely covering the entire body, causes less of sun exposure and also predisposes to vitamin D intake, and therefore predisposes to osteoporosis, right? Apart from nutrition, the second important risk factor is the poor lifestyle. The sedentary lifestyle with a lack of exercise, smoking, alcohol all contribute to osteoporosis. The third modifiable risk factor is use of medications. The important medications include steroids, proton pump inhibitors, GnRH analogs, heparin, and drugs like anti-epileptics, phenytoin. So these are the major drugs which can also cause osteoporosis. Now, how does a patient with osteoporosis present? Usually the patient doesn't know that he is suffering from osteoporosis because it is usually asymptomatic. Sometimes patient can present with back pain. The most common presentation usually are fragility fractures. That is, fragility fracture is a fracture which a patient sustains when he falls from a height less than his own height, right? So if a patient is standing and he falls down and he sustains a fracture, that means it is a fragility fracture. Except finger, toes fracture, this can be sustained by a normal individual also by falling down, right? But other long bone fractures, vertebral fractures, hip fractures, if a patient sustains by falling from his own height, that means the patient is suffering from a osteoporosis related fracture or a fragility fracture, right? So let us talk about when do we screen for osteoporosis. So there are three important criteria when we should screen. These are all Indian guidelines. So first is women aged more than 60 years and men aged more than 65 years. They should be screened for osteoporosis. Second, if there is a post-menopausal women younger than 60 years of age and men between 50 to 65 years of age, when they have any additional risk factor. For example, they are using those medications, or they are having a chronic illness like rheumatoid arthritis, malabsorption syndrome. So any risk factor if they have, they should be screened, right? Similarly, women in the menopause transition age group, if they have any other risk factor for osteoporosis, then they should be screened, right? Then any individual who sustains a fragility fracture even before age 50 years should also be screened for osteoporosis. And then individuals with a condition, for example, rheumatoid arthritis, diabetes, malabsorption syndrome, all of them increase the bone turnover. Also, individuals who are on medications, for example, steroids in a daily dose of more than 5 mg prednisolone or equivalent for more than 3 months, are all associated with low bone mass and should also be screened for osteoporosis. So these are the major indications when we should screen them: women more than 60, men more than 65, postmenopausal women, and men in 50 to 65 years of age group if they have a risk factor, then women in the perimenopause if they have a risk factor, then anyone presenting with a fragility fracture, and patients with conditions or on medications which predispose to osteoporosis, all of them should undergo screening for osteoporosis. This is very important, right? So now what do we do in screening? So broadly, the major test we do is the DEXA scan. So DEXA scan, as we know, is a dual energy X-ray absorptiometry scan which gives us the bone mineral density. So this is a DEXA scan report of a patient. So what does it tell us? It tells us about the T-score. So a T-score is actually a score which compares his bone mineral density with a young individual of his sex. So by a young, I mean an individual who is 20 to 29 years age group. So patient's bone mineral density is compared with this individual, and depending upon that, the standard deviation is calculated. So more than -1 is considered to be normal. Between -1 to -2.5 is considered as osteopenia, and less than -2.5 is considered as osteoporosis. So this is the definition of osteoporosis using the T-score. So the major sites used are: DEXA can be done a 2-site or a 3-site test. So 2 sites usually include a vertebra and hip, and if there is a 3-site, then it can also undergo wrist, because these are common sites for osteoporosis related fractures. So this is how the T-score is given, and we calculate the T-score, and depending upon that, we label the patient as osteoporosis or osteopenia. There is another score, that is the Z-score, that is comparing the patient's bone mineral density with patient of his own age, sex, and ethnicity. So T-score is with a young individual, and this is Z-score is with his own age. So this is the criteria we used using the T-score, right? So apart from this DEXA scan, there is another score which is known as the FRAX score, which we should calculate. So what is this FRAX score? So let us talk about this first. So this is an online calculator which uses all the risk factors that we just now discussed, right? So, and we have to answer yes or no, and depending upon that, it will give us the 10-year probability of a major osteoporotic fracture and a hip fracture, right? So it will tell about this. So all these questions: weight, height, previous history of fracture, smoking, glucocorticoid, rheumatoid arthritis, secondary osteoporosis, use of alcohol, right? And then if the bone mineral density, that is the DEXA report, if it is available, we can enter that. So it can give us a report in 2 formats. One is in this format, when I have not entered the bone mineral density of a patient. So it will tell us about the 10-year probability of fracture without bone mineral density. And if I enter the report, then it will tell us about the 10-year probability of major osteoporotic fracture and hip fracture with including bone mineral density. So this is an online calculator, the FRAX score, which we should use, right? Apart from these 2 investigations, we have certain biochemical investigations. So what are the biochemical investigations that we should get done in a patient with suspected osteoporosis? So as we all know, we'll get a calcium, phosphorus, vitamin D, PTH, right? And serum alkaline phosphatase. What is important to remember here is alkaline phosphatase is a marker of bone formation. So it is usually normal in patients with osteoporosis versus osteomalacia, which is because of calcium deficiency. So in that case, alkaline phosphatase is raised, but here it is normal, right? So apart from these common investigations, depending upon if a young individual develops fragility fracture, then we suspect secondary osteoporosis. So in these cases, we can get done depending upon the indications, screening for Cushing syndrome, screening for a malabsorption syndrome like celiac disease, then screening for diabetes, screening for myeloma, right? So depending upon a number of secondary conditions, whichever can cause osteoporosis, they should screen depending upon the suspicion. Apart from this, there are markers which are known as the bone turnover markers. These are more important when we talk about the follow-up of a osteoporosis patient because they are not much helpful in diagnosis. So there are bone formation markers and bone resorption markers. So formation markers, one we have already discussed is alkaline phosphatase, one is osteocalcin. Resorption markers are type 1 collagen degradation products. And N and T telopeptides, N and C telopeptides. So these are the bone resorption markers. We'll discuss further about them when we discuss the follow-up of a patient with osteoporosis. So these are the investigations that we should get done in a patient with osteoporosis. And once we know that yes, the patient is having osteoporosis, now comes that when do we treat a patient? So the indications of treatment of osteoporosis. So number one is any patient having a vertebral fracture or a non-vertebral fracture by a trivial trauma or the fragility fractures of these sites is an indication for treatment for osteoporosis. Then in individuals with more than 50 years of age with a T-score of less than -2.5 on DEXA scan is an indication for osteoporosis treatment. And third, in individuals with osteopenia, if the FRAX score is more than 3.5 for a hip fracture and the 10-year probability of a major osteoporosis related fracture is more than 10.5, then we should also treat. So these are three major indications, and in patient with diabetes, the cutoff for osteoporosis is taken as -2, right, for treatment. So these are the three important indications we should remember about when to treat an osteoporosis. So what is the management? So management consists of first managing all the modifiable risk factors that include calcium intake. So together with diet and supplementation, the total calcium intake per day should be 1000 milligrams per day. Similarly, the vitamin D intake should be around 1000 to 2000 international units per day to maintain a minimum vitamin D levels of more than 20 nanograms per ml. Then we should undergo lifestyle modification, that is avoiding a sedentary lifestyle, exercise, and stopping alcohol and smoking. So these are the modifiable risk factors we should correct. Now talking about the specific management, the drugs for osteoporosis. So first of all, let us talk about three important drugs. So as we discussed that there are cells known as osteoblasts and there are cells known as osteoclasts which are causing bone resorption, and osteoblast is causing bone formation. So osteoblasts also release factors which are known as rank ligand. These rank ligand bind to receptors present on osteoclasts which are known as rank, right? These receptors are known as rank. So these ligands bind to these osteoclasts and cause conversion of premature osteoclasts to the mature osteoclasts which are causing bone resorption. So this is how this cycle goes on, right? So we have drugs for it. So there is a drug known as bisphosphonates. So the mechanism of action of bisphosphonates is, number one is to cause apoptosis of mature osteoclasts, right? These mature osteoclasts which are formed. Then there is also to inhibit the conversion of premature osteoclasts to mature osteoclast. How does this happen? This happens by inhibiting the rank ligand and rank interaction, right? So it inhibits the signaling pathway and inhibits conversion of premature osteoclast to mature osteoclast, and it causes apoptosis of mature osteoclast by inhibiting the mevalonate pathway. So these are two major mechanisms for action of bisphosphonate. So bisphosphonates are oral and IV both. We'll discuss about them. Then the second drug available is denosumab. So denosumab is a monoclonal antibody, as the name suggests, mAb, monoclonal antibody. So what this is doing is it will bind to this rank ligand and prevents its interaction with rank Therefore, osteoclast is not activated and bone resorption is prevented. So this is also preventing osteoclast activation by inhibiting the rank ligand and the rank interaction. So both of these are in the category anti-resorptives. Now there is a third category of drug which is causes stimulation of osteoblast, that is bone promoters. So this third category of drug is teriparatide. Now teriparatide is nothing but 1 to 34 amino acids of the parathyroid hormone. Parathyroid hormone consists of 84 amino acids, but it causes stimulation of osteoclasts and therefore causes bone resorption. But this 34 amino acid molecule only and only stimulates osteoblasts and therefore just promotes bone formation. So teriparatide is one drug that we can use in osteoporosis. So this is the mechanism of the three major drugs which we can use: bisphosphonates, denosumab and teriparatide. Now, what is the side effects of bisphosphonates and denosumab? Let us talk about them. Bisphosphonates versus denosumab. So bisphosphonates, if we talk about the oral once weekly, that is alendronate. So these are given orally once weekly, but the major problem is, first, it is to be taken empty stomach. Second, patient cannot lie down for about half an hour after taking this drug. Should be taken with adequate water because it has a higher risk of causing esophageal ulceration, esophageal strictures. So the better drug is a once yearly IV drug, which is zoledronic acid. Now zoledronic acid versus denosumab. So there are some common side effects which include, first, transfusion reactions or acute phase reactions like fever, arthralgias are common in both, right? Next, there is this risk of osteonecrosis of jaw, risk of atypical femoral fracture, atypical fractures of the femur, which are also same in both. Then there is a risk of hypocalcemia with both of them, slightly more with denosumab. So these are three common side effects to both of them. The major difference in them is zoledronate is nephrotoxic. Zoledronate is nephrotoxic. Denosumab can be used in CKD patients, but with caution, especially because there is a higher risk of hypocalcemia when used in CKD, but it can be used with caution. Zoledronate is contraindicated when the GFR is less than 30 ml per minute. It is contraindicated. So this is the one major drawback of zoledronate. And denosumab, the major drawback is if once it is stopped, there is a risk of rebound increase in fractures when it is stopped. So three common side effects and one major difference, that it is nephrotoxic, so contraindicated in people with GFR less than 30, and denosumab causes rebound increase in fracture rate. So the zoledronate, the dose is 5 mg IV given once yearly over half an hour infusion. Denosumab, the dose is 60 mg subcut given every 6 monthly. Right? And if we talk about teriparatide, so in teriparatide, we already discussed it is a 1 to 34 amino acids of parathyroid hormone. So here the dose is 20 microgram subcut injection daily. And the maximum time for which it can be taken is 2 years. So 1 to 2 years it should be prescribed. Why? Because the major trial done on it was done for 2 years. And second, there is a remote side effect in rodents seen of osteosarcoma. So because of this risk, this was seen in only in rodents. So because of this risk, teriparatide is to be given throughout the lifetime for maximum 2 years. So therefore, what is commonly done is to give teriparatide for 1 year, then follow up it with zoledronate, so that we have a reserve for teriparatide for later on also for 1 year. Right? We'll discuss this in detail further. So what are the so how do we choose which drug to give when? Right? So now we know the mechanism. So right. So if there is a patient with vertebral fracture, in that case, the preferred drug is teriparatide. And in non-vertebral fractures, we can use zoledronate or denosumab. Because of the side effects and everything discussed, this is very cheap as compared to denosumab. So this is the drug of choice. Only in CKD patients with GFR less than 30, this becomes the drug of choice, denosumab. Roughly, denosumab cost would be around 18 to 20,000 per dose every 6 monthly. Zoledronate would be around 1,000 to 2,000 rupees per year, right? So this is the major difference in the cost, right? And what if we did this was when there is a history of non-vertebral fractures, for example, fracture of the hip, and this is when there is a history of vertebral fractures. So we give teriparatide. So this teriparatide I told should be given for 1 to 2 years, followed by zoledronate. Again here denosumab can also be given, but zoledronate is the agent of choice. Now what if we are treating based on the DEXA report? So in that case, if the patient's bone mineral density is less than minus 3.5, that is very severe, very low bone mineral density, in this case also we can start with teriparatide. In all other cases, zoledronate and denosumab are the drugs which are preferred, and zoledronate being the agent of choice, right? So being simplifying this, in patients, in all routine patients of osteoporosis, zoledronate is the drug of choice, except in CKD patients with GFR less than 30, denosumab is preferred, right? But if the patient has very low bone mineral density, less than minus 3.5, and in patients with history of vertebral fractures, teriparatide is the drug of choice. So this is in summary the 3 important drugs. Apart from them, what is the role of hormone replacement therapy? So it is, although in postmenopausal women this can be used, but this is only and only used when there is some other indication also, right? For example, the refractory vasomotor symptoms are there plus osteoporosis, then we can use hormone replacement therapy. For isolated osteoporosis, even if it is postmenopausal, we prefer to use bisphosphonates, right? Similarly, there are a new drug known as romosozumab. This is again a once monthly subcutaneous injection. The mechanism is it inhibits sclerostin. So what is sclerostin? It is a normal molecule that is again produced by osteocytes, the normal cells of bone. So it causes, normally it causes inhibition of osteoblasts and stimulation of osteocytes, osteoclasts. So what it causes is, this is sclerostin produced by osteocytes. So it is causing inhibition of osteoblasts and stimulation of osteoclasts, therefore causing bone resorption. So romosozumab is inhibiting sclerostin, antibody against this sclerostin molecule, and therefore preventing osteoporosis. So it is a one monthly subcutaneous injection. It is a new drug in osteoporosis. But what we need to know for management currently is what is zoledronate, what is denosumab, what is teriparatide, right? 3 important drugs. Now, once we have started the treatment, how do we follow up such patients? So initially they should be followed up every 3 to 6 monthly for 2 to 3 visits, followed by annual visit. And what should we ask on follow-up? History of back pains, then physical examination, because asymptomatic vertebral fractures are very common, that is more than 4 centimeter height drop of a patient without their knowledge, right? So their height should be measured on each follow-up visit. Then vitamin D and calcium level should be done initially 6 monthly to target vitamin D of more than 20, and once it is achieved we can do it annually. Then DEXA scan should be done every 1 to 2 yearly. Similarly, FRAX score should be calculated on every visit. And then there are markers of bone turnover that we discussed, C and N telopeptides. So they should be done at 3 months, 6 months and 12 months to see how much there is improvement in osteoporosis, right? So they should fall as we treat osteoporosis. So these markers will go down. These are bone resorption markers, right? So now, can we stop the treatment of osteoporosis? That is, what is the concept of this drug holiday? So let us see if the patient is on bisphosphonate therapy. So if we are giving IV bisphosphonate annually, then it should be given for at least 3 years. And if we are giving oral weekly alendronate, it should be given at least for 5 years. So once the patient has received this therapy for 3 yearly and 5 yearly, and we assess the risk of osteoporosis via DEXA scan, via history, physical examination and FRAX score, and we find the patient in low and moderate risk category, that is, there is no prior hip and spine fractures with a t-score above -1 and a 10-year hip fracture risk less than 3% and a 10-year major osteoporotic fracture risk less than 20% is a low risk category, and this in the range of -1 to -2.5 with other two things remaining same is in the moderate risk category. So in these two categories, we can consider stopping the treatment once bisphosphonate has been received for 3 to 5 years, and we have to reassess the patient every 2 yearly for all these risk factors via DEXA scan, via FRAX score, via history and physical examination, and restart treatment if there are these risks appear again, right? What if the patient lies in a very high risk of fracture, that is multiple spinal fractures with a t-score less than -2.5, or a high risk category, that is patient is still in the less than -2.5 zone, right, without any fractures. So in those two categories, we have to continue the treatment lifelong, right? We cannot consider stopping the treatment. What if the patient was on denosumab? So denosumab, we already discussed that there is a rebound increased risk of fractures if we stop the treatment. So therefore the treatment, the stopping guidelines for denosumab are not well studied. What we can do is we can give denosumab for 5 to 10 years at least, followed by, if the patient falls into these low risk and moderate risk categories, we switch the patient to bisphosphonate, give it for the next 3 to 5 years, reassess the risk and then stop, right? So it should be followed by bisphosphonate therapy, and only then if in these categories we have to stop. Otherwise, continue denosumab for lifelong. Teriparatide we have already discussed that it is given for history of vertebral fractures and with a very low bone mineral density, right? So in that case, it has to be given for 1 to 2 years, followed by bisphosphonate or denosumab therapy, preferably bisphosphonate, and then the further treatment is same, giving it for 3 to 5 years, and depending upon the risk category, we decide whether to stop the treatment or to continue the treatment. Now the last thing, is there a role of combination therapy? Now we said that teriparatide is for very low BMD when it is less than -3.5 and when there is a history of vertebral fractures, because teriparatide is very good for vertebra, right? What if together with this history of vertebral fractures, there is a history of non-vertebral fractures like hip fractures also? Teriparatide has not been very well studied for hip. So yes, we can give a combination therapy like denosumab for this plus teriparatide for this. So these are being developed. Similarly, studies are also going with zoledronate plus teriparatide combinations to treat with patients with a high risk for both vertebral as well as non-vertebral fractures, right? So this was all about osteoporosis. Any doubt you can comment. Thank you so much.